Welcome back to the deep dive. Today we are opening up a stack of source material that is as critical as it is complex. We're looking at the clinical guidelines that govern the management of labor and delivery.
Yeah, specifically, we're going deep on how clinicians recognize and really how they respond when labor stalls. We're talking about the disorders of protraction and arrest.
It's highly technical stuff, for sure.
But our goal here is to break it down, to really extract the functional knowledge so you can get a shortcut to understanding this whole framework.
That's the mission. Because these two core concepts, protraction and arrest, they sound similar, but they lead down radically different clinical paths.
Okay, so let's define them right at the top.
Yeah.
What are we talking about with protraction versus arrest?
So protraction is basically a significant slowdown. Think of it like this. Labor is still moving forward, but it's progressing much slower than you'd expect. It's hitting speed bumps, but the car is still moving.
Still making progress, just slowly. Exactly. Arrest, on the other hand, is a full stop. It's the complete, definite cessation of progress. The process has halted, and despite everything you try, it just won't restart.
And I imagine understanding that difference, a slowdown versus a dead end, is pretty much everything. It's the difference between being patient and, well, intervening immediately.
Precisely. Because that slowdown, the protraction, it carries risks. Increased morbidity, infection, exhaustion for the mother, stress for the fetus.
Right.
But a true labor arrest, when you diagnose it using these really strict criteria we're going to talk about, that means you have to move. You proceed to a C-section, a cesarean section, to safeguard both lives. The whole strategy just pivots on which bucket you're in.
Okay, let's unpack this then. Before we get into the timelines, the hours and minutes, we need the initial framework. Our sources all agree the whole evaluation starts with a mnemonic, the 4 Ps.
The 4 Ps are the absolute scaffolding for the entire clinical approach.
Yeah.
It's a systematic way to look at every single component that could be influencing why labor is stalling.
So it's never just one thing.
It's rarely just one thing. It's almost always the interplay between these 4 factors.
All right, so walk us through them. What are the 4 Ps?
Okay, so first up is passage. This is all about the pelvis, the bony architecture the baby has to navigate. We're looking at its shape, its dimensions, the whole birth canal.
The tunnel, basically.
The tunnel, exactly. Then you have the passenger, that's the fetus. And it's not just about size, though that's important. It's crucially about its orientation, its position.
Okay, so passage and passenger. What's next?
Next is power. This is the engine of labor. We're talking about the strength, the frequency, the efficacy of uterine contractions, and later on, the mother's own pushing efforts.
And the last one?
The last one, and this one is so often underestimated, is psyche. This is the patient's mental and emotional state, her anxiety levels, her pain coping, her support system, all of it.
It's fascinating, isn't it, that in such a physical, anatomical process, the psyche is given the same weight as the size of the pelvis. It just tells you right away this is a holistic evaluation.
It has to be.
Let's delve into those, because understanding the risk factors is how we can start to see why a labor might stall in the first place. Let's start with passage.
Right, the passage, it's about dimensions. And a key risk factor here, which might sound a little surprising, is simply nulliparity.
Meaning it's the patient's first time giving birth.
Exactly.
So why is that a physical risk?
Yeah.
I mean, it's not like the bones actually change shape after a birth, right?
That's a great question. The solid bone structure doesn't fundamentally change, no. But all the soft tissues, the ligaments, the joints, they've already been through it. They've experienced that immense pressure and stretching.
So a previous birth kind of proves the pelvis can do the job.
It proves the passage. It tends to make subsequent deliveries quicker and easier. For a first-timer, the passage is, well, it's an unproven trial. So we also look for other things, physical findings like very short stature or a history of a pelvic fracture that could have narrowed things.
I see. So nulliparity is less about the bones and more about the predictability of the journey.
That's a great way to put it.
Okay, let's move to the passenger, the fetus itself.
Size and position, these are huge variables. So any condition that might lead to a larger than average baby, what we call macrosomia, that's a primary risk.
Like what kind of conditions?
Well, the sources point to a post-term pregnancy, for one. The baby just keeps growing past the due date. Or uncontrolled gestational diabetes is a big one that often leads to disproportionately large fetal shoulders.
A bigger baby is an obvious challenge, but you said position is just as critical. What's the ideal and what happens when it's wrong?
The ideal, the absolute gold standard, is the occiput anterior vertex position, or OA.
Okay, break that down for us.
It means the baby is head down, facing the mother's back. The The smallest part of the baby's head, the back of the skull, is leading the way. This lets the head kind of mold and pass through the pelvis in the most efficient way possible.
And when it's not in that position?
If the baby is, say, facing up toward the ceiling, we call that occiput posterior, or even sideways, the diameter of the head trying to get through the pelvis is it's bigger.
So it creates more friction.
A lot more friction. It requires significantly more power to get through, and it makes a slowdown of protraction far more likely. I mean, a slight misalignment can be the single reason for a complete arrest.
Okay, so we have the tunnel, the passage, and the vehicle, the passenger. Now the engine, power. This seems simple. Stronger contractions are better. But what can diminish that power?
Well, the uterus is a muscle, and like any muscle, it can get fatigued or impaired. For example, an interamniotic infection, chorioamnionitis, can dramatically reduce the effectiveness of contractions. The uterus is basically fighting an infection and trying to labor at the same time.
And what about the one intervention that almost everyone thinks about, the epidural? How does that play into power?
The epidural is a bit of a double-edged sword. It's absolutely transformative for pain, obviously, but it can sometimes relax the uterine muscle just enough to reduce the innate power of the contractions.
And affects pushing too, right?
Oh, absolutely, especially in the second stage. It can dampen or even eliminate the mother's natural urge to push, which means the pushing phase can be longer and require a lot more coaching. It's a trade-off.
But the most important factor for power isn't just what weakens it, but what stops us from being able to fix it.
That is the critical safety check. If the fetal heart rate monitor shows a non-reassuring pattern, if the baby is already showing signs of stress, then your ability to safely boost the power with a drug like oxytocin is severely limited.
Why is that?
Because increasing contractions reduces the recovery time for the placenta to send oxygen to the baby. If the fetus is already stressed, cranking up the contractions could make that distress much worse, even cause permanent harm. So a happy baby is the absolute prerequisite for augmenting power.
Makes sense. Okay,
Yeah.
finally, let's touch on psyche. How can someone's emotional state actually translate into physical progress or lack of it?
It's all hormonal. High levels of stress, anxiety, fear, they trigger a fight or flight response. You get a surge of adrenaline and cortisol.
And those work against labor.
They are direct antagonists to oxytocin, which is the primary hormone that drives contractions. So if a patient is exhausted or feels unsupported, her body can literally struggle to produce the hormones it needs to progress. It's a real physiological effect.
So this whole framework, passage, passenger, power, and psyche, it gives the clinician a map. They can say, okay, power looks good, but maybe the passenger is misaligned.
Exactly. It helps you pinpoint the bottleneck. And once you've done that, you can move on to the timeline and figure out exactly where the patient is in labor and whether they officially meet the criteria for protraction or arrest.
So let's do that. We're moving into the first stage of labor now, which goes from the start of contractions all the way to 10 centimeters. But it's not one big block, is it? We divide it into two very different phases.
That's right. We start with the latent phase. This is the early, often slow, sometimes unpredictable part of labor. Clinically, we define it as any cervical dilation less than 6 centimeters.
And this is where, if things slow down, we get a prolonged latent phase of labor.
Correct. And this is where the time thresholds are, well, they're surprisingly long. It really speaks to how much patience is built into the modern guidelines.
So what are the numbers? How long is too long?
It depends on parity. For a nulliparous patient, a first-timer, a prolonged latent phase is defined as going on for more than 20 hours.
20 hours. Wow.
And for a multiparous patient, someone who's delivered before, that threshold is more than 14 hours.
Nearly a full day for a first-time mother. What stands out to me is that even with those huge durations, our sources emphasize that the risk is pretty minimal, as long as mom and baby are okay. Why can we wait that long?
Because the latent phase is often self-limiting.
Yeah.
The contractions are either going to fizzle out, which tells you it's probably false labor, or they're going to organize and strengthen and transition you into active labor. So as long as everyone is stable, the primary management strategy is just patience.
So what does that look like in practice? Do you just put the patient in a room and wait?
Not necessarily. The default is expectant management. So we might send her for a walk around the unit for a couple of hours, or if she lives close by and seems stable, we might even send her home with instructions to come back when things pick up or her water breaks. The goal is to avoid unnecessary intervention.
But a long latent labor can be absolutely agonizing. That's a huge hit to the psyche we just talked about.
It absolutely is. And the main risk here is maternal exhaustion. That's where therapeutic rest comes in. It's a strategic intervention.
So you're giving medication not just for pain, but for rest itself.
Exactly. We might administer a narcotic or a benzodiazepine, and the goal is to give the patient a period of profound rest. Often, when she wakes up, her body has kind of reset. Either the contractions are gone or she wakes up in strong, active labor. It breaks that cycle of pain and exhaustion.
And if rest isn't the right option, that's when you move to augmentation.
That's right. The other options are to augment with oxytocin or perform an amniotomy, which is just artificially rupturing the membranes to get more pressure on the cervix.
But the key takeaway here seems to be
The crucial point is that a prolonged latent phase on its own is never an indication for a C-section. You augment, you provide rest, but you do not declare failure at this stage.
let's talk more about oxytocin, because it's a huge part of this. It's powerful, but it requires incredible precision, doesn't it?
It's a remarkably potent drug, and it's only safe when it's titrated correctly. The goal isn't just to have contractions, it's to have effective ones. So we use an infusion pump and we slowly increase the dose to get to our goal, which is at least moderate contractions every 2 to 3 minutes, all while watching the fetal monitor like a hawk.
We talked about a non-reassuring fetal status being a hard stop. What are the other major risks we're watching for?
The single biggest fear is overstimulating the uterus. And that leads us to the concept of tachysystole.
Which means the contractions are too frequent or too long.
Exactly. We have a very clear definition. Tachysystole is diagnosed if you have more than 5 contractions in a 10-minute window, or if any single contraction lasts longer than 2 minutes.
And if you hit either of those numbers, the alarm bells go off. Why is that so dangerous?
It's all about oxygen. The uterus contracts, and then it rests. And during that rest period, blood rushes back to the placenta to reoxygenate the baby. If the contractions are too frequent or too long, that rest period disappears.
So you're cutting off the baby's oxygen supply.
You are. And the risks are profound. Severe fetal distress, uterine rupture, placental abruption. It's a true emergency.
So if you see tachysystole on the monitor, what's the immediate response?
First, you turn off the oxytocin. Instantly. Then you reposition the patient, usually on her left side, to improve blood flow. If that doesn't work within a minute or two, you have to give a tocolytic, a drug like terbutaline that will forcibly relax the uterine muscle and stop the contractions.
It's a high-stakes, rapid response scenario.
It really is.
One last point on this phase. There's a real time commitment needed before you can say an augmentation has actually failed, isn't there?
This is such a key point for avoiding unnecessary C-sections. The uterus needs time to respond to the oxytocin. The guidelines are clear. To maximize the chance of a vaginal delivery, you should administer oxytocin for at least 12 to 18 hours after the membranes have ruptured before you diagnose a failed induction or augmentation. You can't just try for 4 hours and give up.
12 to 18 hours. That's another testament to patience. Okay, we've navigated the latent phase. Now let's move into the active phase. From 6 to 10 centimeters of dilation, the expectations for progress here are much higher.
They are, and if things slow down here, the diagnosis changes. It's no longer a prolonged latent phase, it's a protracted first stage of labor.
And this is where clinical thinking has really evolved, right? The old models were much less patient.
Oh, massively. Historically, we relied on something called Friedman's curve from the 1950s, and it set these very strict, very fast minimums for progress.
What were those old benchmarks?
They expected at least 1.2 centimeters an hour for first-time moms and 1.5 for multiparous patients. If you fell below that, you were basically immediately labeled as failing to progress.
And what's fascinating here is that we now know those numbers were just wrong.
They were. Modern data from huge studies shows that those old benchmarks led to an incredible number of unnecessary C-sections. Clinicians were just pressured by the clock. We now know that many labors progress safely at a much slower pace, as long as mom and baby are stable.
So if we have a protracted first stage now, a major slowdown after 6 centimeters, the focus is on fixing the two Ps we can actually change: power and passenger.
Correct. But again, the absolute prerequisite is a reassuring maternal and fetal status. If the baby is showing any signs of distress, we skip all of this and move to delivery.
When we need to augment power at this stage, we have to measure it first. This brings us to the intrauterine pressure catheter, or IUPC. Why is that so important?
Because an external monitor can tell you when a contraction is happening and for how long, but it has no idea how strong it is. It's blind to the actual pressure inside the uterus.
And the IUPC gives you that number.
It gives you a hard number, an objective pressure measurement. This lets you move from subjective words like mild or moderate to precise data, which you absolutely need for titrating oxytocin safely.
And that data allows us to calculate the clinical gold standard for uterine work. Montevideo units, or MVUs.
Exactly. MVUs are the definitive objective measure of the work the uterus is doing. To calculate it, you just look at a 10-minute window, you measure the peak pressure of each contraction above the resting tone, and you add them all up.
So if you had 3 contractions and their peak pressures were, say, 50, 60, and 70, you just add them up to get 180 MVUs.
Precisely. You're measuring the total force delivered in that window. And the clinical goal, the magic number we're shooting for, is at least 200 MVUs.
And if you're below 200,
If the IUPC shows you're at, say, 150 MVUs, then you have an objective diagnosis of inadequate power. That's your green light to increase the oxytocin until you hit that 200 MVU target.
but if you're at 250 MVUs and still not making progress,
Then power is not the problem. The uterus is working its heart out. You need to focus entirely on a passenger or passage issue. It narrows your focus immediately.
okay, besides cranking up the force, what other interventions can we use in this active phase?
Well, we'd perform an amniotomy if the membranes are still intact. Breaking the water lets the fetal head apply more direct pressure to the cervix. And then there's the really critical non-drug intervention, repositioning.
Right, let's talk about that specific technique, the Miles circuit. This is a fantastic example of applying biomechanics to labor.
It really is. The Miles circuit is a structured, 3-step sequence of positions designed to help rotate a malpositioned baby and open up the pelvis. You spend about 30 minutes in each position.
So what are the 3 positions and why do they work?
The first one is the hands and knees position. But it's key that the patient lets her chest drop low. This uses gravity to encourage a baby that's posterior facing up to rotate into that better anterior position.
Okay, so that's for the passenger.
Exactly. The second is a side-lying position, but with one leg stretched out and the other lifted high on pillows. This asymmetrical posture actually opens up one of the pelvic diameters, making the passage just a little bit wider.
And the third step.
Active exercises. Things like lunges or walking up and down stairs. This uses dynamic movement to help jiggle the baby down and navigate through the pelvis.
And you also mentioned the peanut ball.
Right, the peanut ball is great for patients with an epidural who can't move around much. You place it between their legs while they're lying on their side, and it helps keep the pelvic outlet open.
Okay, so we've tried everything. We have MVUs over 200. We've done an amniotomy. We've tried repositioning. How do we finally make the call from protraction to arrest of dilation?
First, you assess. If the cervix is still dilating, even super slowly, you continue the trial of labor as long as everyone is stable. But if there is absolutely no further dilation despite all these efforts, then you diagnose an arrest. And that means a C-section.
And there are very strict time criteria for this, aren't there?
Very strict. To diagnose an arrest of dilation, the patient must be past 6 centimeters, have ruptured membranes, and show no further dilation despite one of 2 things. 1, 4 hours of adequate contractions, meaning 4 hours with those MVUs over 200. Or 2, 6 hours of inadequate contractions, where you've been trying to get the power up with oxytocin but just can't.
That's the core insight right there. If you have 4 hours of maxed out power and nothing happens, the problem isn't the engine, it's the passage or the passenger. The trial is over.
Exactly. The problem is insurmountable at that point. The only safe way out is a C-section.
Incredible. So we've made it through the first stage. We're at 10 centimeters. Now we're in the second stage, from full dilation to delivery. And the focus here shifts entirely from dilation to fetal descent.
This is the pushing stage. And just like the first stage, we have very specific time limits before we diagnose a protracted second stage, which is defined by little to no fetal descent.
What are those time limits for pushing?
Again, it accounts for parity in epidurals. For a nullipurse patient, a first-timer, we diagnose protraction after 3 hours of pushing without an epidural or after 4 hours with an epidural. We give that extra hour to account for the epidural's effect on pushing.
And for multiparous patients, it's shorter.
Much shorter. For them, it's 2 hours without an epidural or 3 hours with one.
And the interventions here are, again, all about optimizing the passenger and the power.
Absolutely. The first and often most effective intervention is passenger optimization. If you suspect the baby is in a less than ideal position, the clinician might actually perform a manual rotation of the baby's head inside the birth canal to get it to that optimal OA position.
And if power is still the issue.
You can continue oxytocin to ensure contractions are strong, and you also use positioning again, having the mother push on her hands and knees, for example.
So you've tried all of this, and there's still no progress. How do you assess the response and decide when pushing is no longer working?
This is where it gets really nuanced. If there is any gradual, slow, but demonstrable descent, and mom and baby are stable, you continue pushing. Descent is a continuum. But if you've tried everything and there is no clear objective progress, you have to move to the next crucial decision, assessing for an operative vaginal delivery, or OVD.
Right. This is the bridge to assistance using a vacuum or forceps.
Mm.
But it's not always an option, is it? There's a big question of whether it's safe.
It depends entirely on a strict, non-negotiable safety checklist. If the situation doesn't meet these criteria, OVD is considered unsafe and you have to go to a C-section.
So walk us through that checklist. What makes an OVD safe to attempt?
Okay, there are 5 key things. First, fetal station. This is how low the baby's head is in the pelvis. It generally must be at least at +2 station to proceed.
What's the significance of +2?
If the head is any higher than that, the risk of the instrument slipping or causing trauma is just too high. The head has to be well engaged in the lower pelvis. Second, fetal orientation. You must know exactly which way the baby is facing to apply the device correctly.
And third.
Third, passage adequacy. You have to be reasonably sure the pelvis is big enough. If you suspect the baby is just too big, OVD will fail and just cause more distress.
Makes sense.
And finally, you need maternal consent, and there's a key gestational age limit. You cannot use a vacuum before 34 weeks gestation because of the risk of intracranial hemorrhage in the baby.
So if any one of those checklist items is no high, the station's too high, the baby's too premature, that's it. It's an arrest.
That's right. If OVD is deemed not appropriate, you diagnose an arrested second stage of labor and proceed immediately to a C-section. All other options have been exhausted.
But let's say the checklist passes and the OVD is attempted.
Yeah.
What if that attempt itself fails?
That is the final arrest point. If the device is applied, but the baby doesn't descend with appropriate traction, that's the end of the line. You diagnose an arrest of the second stage of labor and you move to a C-section. It means the passage-passenger mismatch was truly insurmountable.
A final high-yield fact before we wrap up. The third stage of labor. It's short, but it's critical. This is after the baby is born, but before the placenta is delivered.
Right. This stage is usually over in a few minutes, but clinically, the clock runs for up to 30 minutes before we call it a protracted third stage.
And the big risk here is postpartum hemorrhage.
Precisely. If the placenta doesn't detach, the uterus can't clamp down, and that can lead to life-threatening bleeding.
So what's the management to prevent that?
We use what's called active management. This means right after the baby is born, we give uterotonic drugs like oxytocin and use uterine massage to encourage the placenta to detach and the uterus to contract firmly. It dramatically reduces the risk of hemorrhage.
This has been an incredibly detailed journey. Let's do a quick summary of that flow from protraction to arrest.
Okay, in the first stage, protraction is about those long time limits, 20 hours for a first-timer. Interventions are all about objectively fixing power to get over that 200 MVU target. Arrest is called after 4 hours of adequate power or 6 hours of inadequate power, which then leads to a C-section.
In the second stage, the pushing stage. Protraction is about the pushing time limits, 3 or 4 hours. Interventions are mechanical manual rotation of the baby, more pushing positions. The end of the road is that crucial OVD safety checklist.
Right. And if that OVD is unsafe, or if it's attempted and fails, that is the definitive arrested descent mandating a C-section.
If we pull back and look at the bigger picture, this whole modern framework seems to be about one thing: moving away from arbitrary clocks and towards patience that's guided by objective data.
That's it exactly. We allow so much more time than we used to, prioritizing a safe trial of labor as long as the objective metrics fetal status, MVUs, look good. It's measured patience.
So what does this all mean for you, the listener? We've unpacked this really delicate balancing act between allowing the natural process to unfold and knowing exactly when to step in with timely evidence-based intervention.
Right, and it all hinges on these strict objective thresholds, that 20-hour limit for the latent phase, that 200 MVU target. It's all about applying hard numbers to a process that is fundamentally biological and, incredibly variable.
Which leaves us with a final thought for you to consider. How much of this optimal weighting is a function of pure science and safety checklists, and how much is it really an acknowledgement of the profound, unpredictable variability of the human body, which simply demands this incredible patience?
The guidelines themselves are really the attempt to harmonize those two things, to bring objective science to a subjective biological process, all to get the safest outcome possible.
Thank you for joining us for the deep dive. We'll see you next time.